Well, good afternoon, friends, I think. No, good morning, friends. Good way to start. I would just like to start by acknowledging the traditional custodians of the land that we find ourselves on here in Melbourne, Naarm, the Wurundjeri Woi-wurrung people of the Kulin Nation and elders past, present and emerging. I'd also like to acknowledge any First Nations leaders in the room today and again use this opportunity as I try to use any opportunity to reaffirm my commitment and our agency's commitment to fairness, to truth-telling and ultimately to a pathway towards treaty for Victoria. The 2024 World Health Summit Regional Meeting in the Asia Pacific comes at a critical time for the global health community. As a global health community, we must identify the common grounds from which we can best meet the shifting and complex societal challenges, and we must strengthen and underline the underlying systems and intersectoral partnerships that allow us to address them together. It is fitting that our opening plenary brings us all to set the tone on shaping the future of health across Asia and the Pacific. My name is Dr. Sandro Di Maio. I'm the CEO of Vic Health, and it's my pleasure to be chairing this opening plenary. Our panel today will each share their important and diverse perspectives, drawing from their deep regional and global expertise and leadership. Please join me in welcoming to the stage our esteemed panel, Dr. Saya Mayu Piukala, Regional Director for the Western Pacific region of the World Health Organization, Dr. Ambassador Lucas Detoka, Ambassador for Global Health and First Assistant Secretary at the Department of Foreign Affairs and Trade in Australia, Professor Adiba Professor Adiba. I've even been practicing, I'm so sorry, Adiba. CEO Kamarulzaman, sorry. Kamarulzaman. Prof. Adiba, CEO of Monash Malaysia and Pro Vice Chancellor and President of Monash Malaysia, and of course, Professor Ilona Kickbush, Founding Director of the Governance Health Centre Graduate Institute in Geneva. So as I mentioned, my name's Dr. Sandro Di Maio. I'm the CEO of Vic Health, the world's first health promotion foundation. And Vic Health is proud to be a major event partner of the 2024 World Health Summit Regional Meeting hosted by Monash University. As a WHO collaborating centre on health promotion, we have a strong history of working together to improve the health and well-being of people within our great state, our region, and of course, around the world. The 2024 World Health Summit Regional Meeting in the Asia Pacific comes at a critical juncture for global health. As we convene to unpack and define the future of well-being across our dynamic region and delve into discussions focused on the urgent need for systemic action to achieve health equity, it's essential to recognise our shared and unprecedented challenges and unparalleled opportunities. The Asia-Pacific region, diverse in its cultures, populations, epidemiology and health systems, shares common foes: widening health disparities, the resurgence of deadly big tobacco, now big vape, the real consequences of an unstable climate, the ongoing impacts of preventable disease, and the ever-looming threat of infectious pandemic. Just 4 years ago, COVID-19 swept the globe. While it highlighted how interconnected and interdependent we are at the planetary scale, as our global community broke records and overlooked differences to drive innovation in technology, from vaccines to healthcare and scientific achievement more broadly, it revealed very real failures. And it shone a light on the deep cracks of systemic inequity that have long been papered over and forgotten. Poverty and poorer health, both preventable, saw populations put at avoidable risk. As the pandemic continued, we then failed to act as one humanity. We left huge parts of the global community behind and allowed misinformation and distrust to spread like wildfire, all with disastrous consequences for health. While we battled one immediate threat, others other critical health challenges loomed larger every day. Climate change is no longer some distant concept or future ultimatum. It is here, and it is impacting the lives and health of every community across our planet. It is deepening and entrenching intergenerational poverty. It threatens to put food security at risk for millions. And we're already witnessing the spread of diseases into previously protected populations and geographies. In short, climate change is the greatest health challenge of our age and has the potential to undo all progress in health gains. As we transgress yet further planetary boundaries, the very planet upon which we as a species rely is at risk. Our collective future is in question. Alongside and linked, our economic divides continue to widen. Decades of exploitative economics is resulting in the concentration of wealth and opportunity. With the planet's richest 1% now enjoying more than 45% of global wealth, the same group has enjoyed 2/3 of all new wealth creation since 2020. Here in Australia, the current cost of living crisis is very real. It sees parents skipping meals to feed their kids, and families making tough decisions as they turn to cheap, processed foods to make ends meet. And while the global political and geopolitical tensions escalate and public trust in government institutions and governments themselves erodes. A fractured media landscape and the rise of big tech presents our health community, with further significant communication challenges to warn audiences at risk. We now live in a region where by the age of just 13 years, big tech will have collected 72 million data points on our children. This data is sold to the highest bidder and weaponised to push products, often associated with disease, upon children who are still building their fundamental understanding of the world. In 2024, we find ourselves asking, how have we allowed commercial actors to have more control over our health than we do, or than our governments? How do we achieve meaningful gains, health gains, when 80% of health outcomes are driven by factors outside our siloed health systems? How do we move from making hollow collective promises and setting yet more health commitments to making meaningful action? First, we must confront the stark reality of widening health inequity. Our health is shaped by the way our systems are designed, and they are designed by people in power to benefit the few, often at the cost of many. An unacceptable majority of individuals and communities continue to be marginalised and left behind, undermining the fundamental principles of health for all. It requires humility, recognising the expertise of others, listening to diverse perspectives, and being open to learning and adapting. Ultimately, it requires empathy, trust, respect in our efforts to promote health and wellbeing. What does this mean for our region here in the Asia Pacific, where our systems have largely been designed by powerful people whose world is centred in a different region from our own? By working together across disciplines and sectors, we can foster more resilient and equitable systems for health that truly leave no one behind. Local is not the antithesis of global. In an increasingly interconnected world, the health of one community, of one region, is inextricably linked to the health of all. As such, we must reaffirm our commitment to multilateralism, cooperation, and diplomacy as essential tools for promoting health and wellbeing at the global scale. Every day, I'm inspired by the advocacy and ingenuity of local communities across our state and around the world, using their voice and power to shape a better, fairer, and more inclusive future. Global action always starts locally, but local leadership needs our support. Over the next 3 days, we owe it to the communities that we serve, work within and alongside, to confront and tackle these big issues. Look around you. You are surrounded by some of the brightest minds in our region. Ecological, equitable, existential. It is our responsibility to use this summit to align on action. This is not a conference or a convening to simply passively listen and pat each other on the back. Let's look beyond the next 5 years and make sure that at the dawn of the 2030s, we look back and agree that this summit was a turning point, a collective moment of alignment and a launch point for momentum. Together, let us shape the future of health across Asia and the Pacific and beyond. It is now my absolute pleasure to introduce our very new Regional Director from the Western Pacific region of the World Health Organization, Dr. Saya.
To our distinguished organizers, Co-President, Professor Christina Mitchell and Professor Sophia Sunkas. To our partner and host, Monash University. To the Honorable Excellencies, the distinguished guest participants from across the region. And to our chair, Dr. Sandro, and my fellow invited speakers. I would like to thank Dr. Mandy Nicholson for welcoming us to her country, and also would like to acknowledge the Bunwurrung and Wurundjeri people of the Kulin Nation as traditional owners of the land. And I pay my respect to their elders, both past and present. It's an honor to join you today this morning at this year's World Health Summit Regional Meeting and share a few thoughts with you at this Grand Challenges plenary, and what a set of grand challenges we face. Earlier this month, we celebrated World Health Day with the theme, My Health, My Right. Ensuring the right to health for all people has never been more important as our world grapples with multiple crises, from diseases to disasters, conflicts, and climate change. While this region has made significant gains in reducing infant, childhood, and maternal mortality, and life expectancy have become longer, but in the post-pandemic period, we are seeing declines in many vital health statistics. And in too many parts of this region, there are two types of healthcare systems. One for the rich and one for the poor. 2 out of every 5 people living in the Western Pacific still can't get essential health services. And that is a staggering 782 million out of the 1.9 billion people in the region that are struggling to find the basic care they need. These are the problems of today. But if we can't find a way to get them right, there will also be our fate of tomorrow. It feels big. It feels overwhelming. It can feel like the challenges are insurmountable. Sometimes the scale of the challenges can make us think that the problem is out there beyond our grasp, beyond our ability to act. We can hear this way of thinking in our language. We can only react and mitigate, shape, and encourage. Let me suggest that the very words we use reflect a shrinking of our imagination in the face of such grand challenges. It reflects a caution in what we dare to deliver by ourselves and with each other. In the face of such challenges, what will it take to create, to ensure, and to sustain good health? The organizers of today's session rightly identify solidarity as one key of the solution. identifying common grounds, standing together. Solidarity is important. It is a core value in our region. But I also want to look beyond solidarity, because solidarity is only possible as a result of respect and of mutual trust. And this only comes with a true knowing of one another. At their core, solidarity, respect, and trust are deeply rooted in community. Ladies and gentlemen, good health is more than the topic of discussion among experts. It is more than the words written into a policy. It is more than the ideas captured in grand programs designed in capitals far away. Good health is the living product of our social fabrics. Good health is the living reflection of the cultures, traditions, and values we hold dear. Let me not be misunderstood. There is a time and place for grand visions and global movements. But the playing board is tilted. Money, time, and resources go to fund global priorities that are too often far removed from the realities of local communities. In 2024, it is long past time to zoom in, to hyper-focus on our communities, and with a country-first and community-first strategy that is more than a slogan. In the past 3 months, I have been traveling throughout our region following my appointment as WHO new Regional Director for the Western Pacific. I have seen and heard the passion and the dedication of so many of you and our partners to making our region the healthiest and the safest. And our priorities are as clear as they are shared. First, promote an integrated approach to health system development, which uses primary health care to achieve universal health coverage. And that is how we will address the leading causes of disease and the inequities I have described and ensure people live not just longer, but healthier lives. Second, accelerate action on climate change and health. This is a threat that affects us all. In this region, we all know the profound impacts that climate change will have on health, from the impacts of air pollution on the lungs of our children, to the spread of mosquitoes to areas where we thought malaria was long gone. But the rest of the world has not yet fully arrived at this understanding, and our future depends on us being able to bring others along from outside of the health sector on this journey. Third, to build on the lessons on the last pandemic before the next one arrives on our shores. Ladies and gentlemen, I don't need to tell you how important it is we get this right. We have an obligation to all those we lost to do so. And right now, we have once-in-a-generation opportunity to expand equitable access, improve coordination, and prevent loss of lives and livelihood through the negotiation of a new pandemic agreement. These are our priorities, but to achieve these goals, we will need new ways of working. Let me suggest to you today that achieving these goals depends on the extent to which we listen to and engage with our communities. It depends on the extent to which we consider the nuances of culture and tradition, the extent to which we understand the individual as part of the whole. What does this mean in practical terms? It means we promote health by advocating for policies that are grounded in communities' culture, identity, and diversity. We succeed by recognizing the importance of people's interaction with the environment where they live, enabling readiness and resilience to face climate change. We strengthen the policy environment for regulation of tobacco, alcohol and electronic nicotine delivery system by adapting to the unique and localized policy environments and legal systems. It means we provide better access to health services through transformative primary health care integrated into the life of families and communities. It requires sharpened apples and evidence-based disease control and approaches that are open to using a range of platforms, including traditional medicine as well as digital health technology. We also provide better access by reinforcing a holistic understanding of health, including oral health and mental health programs adapted to country contexts and integrating disability prevention and rehabilitation so that all people of all ages in all communities will have access. And lastly, it means we protect people from outbreaks and disasters by extending and strengthening surveillance and detection into the communities, adapting approaches for early action, and improving multi-sectoral policies and approaches, including One Health. Ladies and gentlemen, I stand before you today as WHO First Regional Director from the Pacific. The magnitude of this is not lost on me, nor is the weight of the responsibility. And as I look around this room today, it is humbling to be standing amongst the giants of public health and world leaders. But it is also heartening to see people from so many corners and crevices of our vastly diverse region. Representation matters. Each of us have so much to share and contribute. Lessons learned from as far as the steppes of Mongolia can be applied to the hard-to-reach communities in Australia. And I am eager to see how the experiences of the Pacific can enrich the region. You are no doubt familiar with the tradition in many parts of Asia and the Pacific, in which families and communities come together to weave mats as part of our culture. Each member of the community contributes their part, and from those parts we make a whole woven mat. In our region, we must do the same, bringing together our similarities and differences, our skills and resources and experiences, and weave our mat of health together. This is our challenge and our shared vision to providing access to health services by promoting, providing, and protecting health in our region over the next 5 years and beyond. And as you take part in the list of sessions over the next several days, I would like to issue a set of challenges of my own to you, for you to consider. To what extent are we rooting our analysis of the problems or identification of solutions in the voices of the people most affected? To what extent are we relentlessly adapting approaches for local context, culture, or tradition? To what extent are we capturing local innovations? To what extent are we even there to observe them? And finally, are we measuring impact at the local level? Disaggregating and analyzing impact in community? And interrogating the numbers of what it means in gaps or uneven result in people saved, number of lives saved, protected, or extended. I ask you to keep these questions in mind over the coming days and bring strands of your own insight and experience to the discussion, weaving a rich mat of diversity, cultures, and identity to the meeting and its outcomes. I wish you all a very successful meeting, and I thank you.
Thank you, RD. Rather than getting up and sitting down 4 times, if you all are happy and comfortable, I'll introduce you from here. So thank you, RD. And now it's my absolute pleasure to introduce my good friend and our brand new, well, relatively new Global Health Ambassador from Australia, Ambassador Dr. Lucas de Toca.
Thank you, Sandro. Minister Carney, Minister Thomas, co-presidents and organisers of the World Health Summit, distinguished colleagues, Nisambula Vinakasaka Ratu Antonio Lalambalavu, Minister for Health and Medical Services in Fiji. I still struggle not to call Dr. Piukala Minister, but Director Saya from the World Health Organization, esteemed co-panel members, Right and Honourable Helen Clark, volunteers who are making the summit happen. So thank you for being here and supporting this. It's wonderful to be here. Apologies, those who've heard me speak before know I'm always a little bit scattered. Today I'm going to be more scattered than usual because not to minimize the real impacts of climate change, but I was meant to arrive on Saturday night from Geneva. I only got in last night. I slept 4 hours because of floods in Dubai, floods in the desert. Apologies in advance. I also want to thank Dr. Mandy Nicholson for welcoming us to her country, and I also acknowledge that we are on Punwarang and Wurundjeri traditional land, and acknowledge the elders past and present from the Kulin Nation and any First Nation colleagues with us here today. The scale of the summit and the fact that it's happening here is huge, and we're incredibly excited, and that you've all been able to join us in Melbourne to talk about the issues in our region and how the interconnectedness between what's happening in the broad world, but also the perspectives that we have in a little corner of the planet with the largest ocean in the solar system, bring to the global health table. We really welcome the discussions that will happen in the next 3 days. The presentations, the 200 speakers are amazing, but from these events, it's almost more important the chats that happen in the hallways, the friendships that are made, the partnerships, the networks, the fact that after this, you'll be able to pick up the phone and talk with experts, colleagues that are dealing with the same issues that you're dealing with in the other side of the world or in a neighbouring island in this region. So it's great that this can happen, and please make the most of it by talking to as many people as possible and making new connections and friendships. Both Minister Wong as well as many of the speakers throughout the opening have talked about perspectives. And we think the importance of sharing different perspectives, having diverse views, is what events like this bring up. And also that things are not always in Berlin, Geneva, New York, etc. Nothing wrong with Berlin, Axel. We're talking about the complexity of the challenges, and they are well known, and they have been mentioned by the speakers before me from this morning. But things are getting more and more complex. Things are more interconnected. It's good that we have more awareness of the complex systems that interplay everything. Even a couple of decades ago, social determinants of health weren't a given in medical curricula. And now we're talking about commercial determinants and intergenerational trauma. So there's more awareness, but also the complexities are getting more so. We're in a post-pandemic or post-emergency phase of the pandemic environment in which health budgets are and will be more constrained. Health ministries everywhere facing finance ministries that are saying, you had your day. There was a massive health expenditure with COVID, we need to rein in. And in many cases, there's really no more budget to spend. We are seeing that in the region where the percentage of debt repayment as part of public policy expenditure has ballooned with some of the COVID pain that governments have to face. And so the funding available for health, including global health, is not going to get bigger in the foreseeable future. So we need to operate within that constrained environment. Human rights, including sexual and reproductive health and rights, are under pressure. We have seen things that hadn't been questioned in decades now being questioned. We are struggling to get terms like gender-responsive care in any resolution, including in bodies like UNAIDS that focus on priority population. And yet, nearly half of all pregnancies in the world are unintended. Not necessarily unwanted, but unintended. So we've got a long way to go to achieve any form of equality. Supply chains for health remain challenged and need to be strengthened. Misinformation and disinformation has been mentioned before, and mean that the trust in public health institution is eroded. And of course, climate change is putting all of this to a test, and many parts of society are still talking about it as if it's something in the future, as opposed to what we're experiencing right now. High inflation, domestic cost of living pressures, conflict and geopolitical tensions, and escalating conflict in many parts of the world, and urgent need for energy transition are understandably focusing government's priorities. So it's not health that it's at the center stage at the moment. So we need to be smart and operate within the resources that we have and make the most of the partnerships that we have to actually tackle these challenges together. So what is Australia doing about this, and what's Australia's role in all of this? Well, of course, we are a high-income country, so we're a donor. We have, I think the stat is, if not the highest, the second highest rate of WHO collaborating centres per capita in the world. Didn't know that was a metric, but it is, and we're up there. And sure, so we can be a source of expertise, but that's what a lot of high-income countries do, and that's what we've done traditionally, and we have great examples of that. Ratu Lalambalavu knows well some of the collaboration with the Fijian government during COVID meant that Fiji went from one location with PCR capability to 107 molecular testing sites, including in the outer islands, just because of the use of that technology during COVID that then was repurposed for broader health system use. And now they're doing whole genome sequencing in 2 sites on the main island. So yes, of course we can facilitate that from a more traditional donor kind of way. But the shift, and Minister Wong referred to it in the last couple of years, and with the launch of our new international development policy, is that we're acknowledging that Australia does bring a bit of a unique and rich perspective. We are home of the longest continuous culture in human history, and the acknowledgement of country and the welcome to country that you have seen, I always say it because I'm an Australian health diplomat, and this is a diplomatic tool. We often forget, and it's like something nice that we do at the beginning to acknowledge the traditional ownership, but really it is a formula that predated colonisation. It's a way to acknowledge that you're in someone else's land, identify who you are, and seek safe passage. So that had been happening on this continent for 60,000 years, and now we're adopting it as part of a diplomatic practice. So it is the oldest Australian diplomatic practice, and probably one of the longest continuous one currently used in human history. But we're also a migrant country. We're one of, I think, 5 countries where more than 20% of the population was born overseas. It's 28% for us. More than half of all of Australians, as of the last census, 51%, have either one parent born overseas or have been born overseas themselves. We hail from 300 ancestries across the globe. I mean, we even found some random Spanish doctor who became Australian 6 years ago and made him our global health ambassador. How progressive. So that puts us in a unique position. We are incredibly connected to the world. We have ancient customs and ancient knowledge, but we also have connections to essentially every part on the globe. And that allows us to play often, as we are doing with the Pandemic Accord back in Geneva, a bit of a bridge building role. We are in the south, but we are part of the global north. We are a Western country, whatever the hell that means, but we are in the east. So that being of the north and the south, of the east and the west, puts a capacity but also a responsibility for us to bridge some of those divides, which we are very committed to do. So we have a lot to offer, but we also have a lot to learn. We talk about things like TB, rheumatic heart disease, as global south, I hate those terms, problems, but we have TB in many parts of our country. We have some of the highest rates of RHD in Northern Australia. So we have a lot to learn from working with neighbours in the Pacific, working with neighbours in Southeast Asia. We face some of the same challenges, and we can work on them together. We also acknowledge that we're not an impartial observer. We are not, the neutral position that sometimes in a slightly post-colonial approach, donor countries have put themselves as we're just arbiters with money. No, we have baggage, positive and negative. We are part of this region. We have a shared history, often painful. We've done a lot of good, and we also haven't. And we bring all of that to the centre when we engage honestly and truthfully in the region. We are super excited to have our first Pacific Regional Director with Dr. Pikala. We're also really happy that we have Dr. Emilia Latu Afuhamango Tuipolotu as the WHO's Chief Nursing Officer. So hopefully the Pacific takeover is taking place one step at a time. Elevating those perspectives is really important. I was in Geneva last week, and there was barely any acknowledgement or mention that the lowest vaccination rates in the world are in PNG. Yet the focus is in other parts of the world, which of course have high need. So we need to be there. We need to support our colleagues from the region being there. There's great examples of what our region can offer, but I'm also conscious that I'm running out of time, so I'll probably wrap it up now and we can explore that in the questions. But essentially what my mandate is, what Minister Wong told me when I got this role, that my main focus was to making sure that the global health system focuses on equity, and also and more important, not more importantly, but more specifically, that means that Pacific and Southeast Asian perspectives are represented in that global health system, and that the global health system works for this region. Because the challenges that we face, the complexity, the different economic mix, the variation that we have in small island developing nations, means that if we design a global health system that can tackle that diversity and address the needs of such a varied region, such as Wipro or CRO, we have probably set it right to be equitable for all. So that's what we're committed to, and we're keen to explore in this meeting. Thank you.
Thank you. Thank you, Ambassador. It's now my pleasure to introduce Professor Camaralzaman, or Professor Adiba, CEO of Monash Malaysia and Pro Vice Chancellor and President of Monash University Malaysia campus.
Thank you, Sandra. You know, I often joke that I would like to be as famous as Madonna, so being known as Adiba alone is enough. But I'm giving my age away a bit. I should say I won't be as famous as Adele or Beyonce. First of all, allow me to also acknowledge the traditional owners of the land by which we meet and elders past and present. We've heard through the opening ceremony this morning and also by our two speakers how complex and diverse Southeast Asia and the Pacific is, and I've been given the task to speak about Southeast Asia and try and bring some numbers to it and bring to life how complex and diverse the region is and the challenges that we face. First of all, diversity. We're home to almost 700 million people, that's Southeast Asia, with 100 ethnic groups and more than 1,000 languages and dialects. But we're also growing at 4 to 5%. And that diversity means we stretch from the east all the way to, if you bring, to Myanmar and others. So that's a big piece of land that we cover, with a very, very rich history and socio-cultural diversity, and also huge economic differences from very wealthy countries such as Singapore, Japan, Australia, to some of countries with the lowest Human Development Index and GDP. So that makes us extremely complex. We also have a demographic evolution that's undergoing significant changes over the past half century, with declines in fertility and mortality. And compared to other world regions, Asia and the Pacific is aging most rapidly, bringing with it inherent problems and challenges once again. We're home to countries with some of the lowest fertility rates and highest life expectancies at birth and at older ages. And this region probably sees some of the largest migration within and beyond the region. We're host to 20% of 164 million migrant workers, with distress migration features in certain corridors in the region, notably from Afghanistan, Bangladesh, and Myanmar. And with this, a significant proportion who are not covered by any social protection, and 40% have no access to health care. We've also heard that we're one of the most disaster-prone regions in the world and most vulnerable to the adverse impacts of climate change, including rising sea levels, heat waves, and floods. And according to a study published in 2021, the Philippines, Myanmar, and Thailand rank among the top 10 countries in the world for climate-related loss events between 2000 and 2019. And if we include Cambodia and Vietnam, who are also in the top 20. 19 of the 25 cities most exposed to a 1-meter sea level rise are in our region. We have the most divergent health status and health systems across and within countries. I've touched on the socioeconomic differences by GDP per capita, education, health expenditure are all varied very widely in our region. The gap in life expectancy is as high as 20.1 years, with the lowest being 64 years in Tuvalu and the highest being 84 years in Japan. With this, we see huge disparities in NCD mortality by selected macro-level factors in our region. And naturally, many are related to socioeconomic and other related risk factors. More numbers for you. The highest age standardized mortality from NCD was 1,281 per 100,000 population in Kiribati, which is 5 times higher compared to Singapore, which has an NCD mortality of 235 per 100,000 population. And these risk factors are aggregated by different types of features, including income group, geographic, or cultural factors. When it comes to disparities, of course, COVID-19 exposed the underlying health system shortcomings and social and economic inequities, not just between countries, but within countries, which increase the risk of very vulnerable populations, such as migrant workers. A feature of the COVID-19 problem, both in my own country, Malaysia, and in Singapore. The urban poor, the elderly, particularly those living in nursing homes, and key populations, in the language of the HIV community that I work in, people who use drugs, sex workers, transgenders, where we saw huge service disruption for both prevention and treatment, and gender-based violence. And finally, large numbers of people in prison were affected by COVID-19. So these disparities played out very, very large during the COVID-19 pandemic. Within the region, we're seeing diseases change from traditionally the burden of communicable diseases now to a very large NCD burden. So the Southeast Asia region faces dual burden, or triple if you consider aging as a burden, which we shouldn't. In terms of diseases, we have a large NCD burden and communicable diseases, although by and large the incidence and prevalence are decreasing, but they still remain a threat. So some numbers on NCDs. When we consider cardiovascular diseases, chronic respiratory diseases, diabetes, and cancer, they are the top killers now in Southeast Asia, claiming an estimated 8.5 million lives each year. In the CRO region, the 4 NCDs together cause nearly 2/3 of all deaths in countries, and shockingly, half of these deaths occurred in the age group 30 to 69 years. In the Wipro region, NCDs accounted for 12 million deaths in 2019. And this represents a proportion that is disproportionately higher compared to the global data. The International Diabetes Federation notes that 1 in 11 adults in Southeast Asia and 1 in 8 in the Western Pacific region had diabetes in 2021. with a projected 68% and 26% increase respectively by 2045. So, Madam Chair of the World Health Summit co-chair, Sophia Zungas, you have a lot of work to do ahead of you in the region. 74,000 and 2.3 million deaths in 2021 were attributed to diabetes in the Southeast Asia and Western Pacific regions. Now back to my own country, Malaysia, which is aspiring to be in the, it's now in the upper middle income. It hopes to be considered as a high-income country by 2030. We're facing, again, a dual problem of NCDs and infectious diseases, with some horrific numbers of over 53% of Malaysians screened during the National Health and Morbidity Survey in 2021. Over 53% of Malaysians are either overweight or obese, so 1 in 2. With a prevalence of diabetes of 17%. But that's not all. And in both Malaysia and Indonesia, not only are we experiencing the epidemic of NCDs, but we're also grappling with traditional problems of low-income countries, which is that of malnutrition and wasting. So in sort of increasingly wealthy Malaysia, as I said, 1 in 2 adults obese or overweight, but 20% of children under 5 also suffer from stunting and 11% from wasting, when you have nearly 13% of children who are obese. And this, I believe, is also what is being experienced in Indonesia, which is simultaneously burdened with under- and overnutrition. When it comes to communicable diseases, as mentioned, we've seen an overall decline in disease burden, but we continue to have threats of infections like TB, HIV, malaria, hepatitis, and diarrheal diseases, and of course, dengue. According to the global TB burden from 2020, Southeast Asia accounted for 43% and Western Pacific for 18% of the global TB burden. And the Western Pacific region has the largest burden of chronic hepatitis B globally, with nearly 40% of all cases in 2019. In Pacific Island countries in 2019, the main attributable risk factors for communicable disease include child and maternal nutrition and basic human rights of unsafe water, sanitation, and hand washing. A bit more on TB. As mentioned, 43% of global cases occur in our region, but China shoulders approximately 10% of the global burden of multi-drug resistant TB, adding more complexity to the health challenges in our region. Very quickly on a disease that I have spent a large part of my career on, HIV. 4.2 million people living with HIV in this region are now receiving antiretroviral therapy, but when we compare ourselves to sub-Saharan Africa, we are not, for many reasons, not doing as well, including in prevention of mother-to-child transmission, where we've only reached 57% coverage, which is well below the global coverage, well below the global average of 82%. Now, when you think that the clinical trials, the landmark clinical trial of ACTG 096, I think it is now, it's that long ago, that told the world how we can best prevent mother-to-child transmission, happened in 1998. It really is a shame to us all working in this area that prevention of mother-to-child transmission of HIV is still only at 57% in 2023. Now, why do we have this? Well, I think in the region where HIV is largely concentrated amongst what we call key populations, where half of people who inject drugs, female sex workers, male sex workers, gay men and other men who have sex with men, and transgender people who are incredibly stigmatized and discriminated upon. It is not a surprise that we still struggling with reaching the 95 goals of HIV elimination. Although there is evidence of progress, 39 countries in this region still have laws that impede HIV response. 38 criminalize some aspects of sex work, 17 criminalize same-sex relationships, 24 laws that do not allow possession of limited amounts of drugs for personal use, 19 criminalize transmission or non-disclosure of HIV, and 15 restrict the entry, stay, and residence of people living with HIV. Very quickly on dengue, which is now not just limited to our region, it's now making a huge surge around the world with global warming, including in the Americas. From 2000 to 2019, there was a documented tenfold surge in reported cases worldwide. And a very, very quick note on antimicrobial resistance, given the time that we have, but it is, next to climate change, probably one of the biggest global crises that we often don't speak about as much as we do the other diseases. And a new addition to the non-communicable disease, which is mental health. Over 215 million people in this region suffer from mental health conditions. In the Global Burden of Disease study of 2019, it was noted that there was a significant increase in the Western Pacific region in mental health from 1990 to 2019. And of course, COVID-19 pandemic has just exacerbated it even further. And because of the deep stigma and that there is a huge barrier for people suffering from mental health in terms of coming forward seeking health services. So I hope I haven't completely depressed all of you with the figures that I've shared about the state of health in Southeast Asia and the Pacific. I think there are many things we can do for the future, and I'll leave it to for when we discuss. But the good thing is this is also the region that is surging forward economically. Like I said, many countries in the region fall into the either emerging economies or doing very well. And I think there is really a huge opportunity, particularly for countries who are shaping their health system, who are shaping digital health, to not be saddled with some of the legacy systems and to really design health that, and also rebuild health systems after the COVID pandemic that is patient-centered, that integrates infectious diseases and non-communicable diseases all the way from prevention, diagnosis, treatment, and care, to invest in digitalization, and last but not least, to invest in human rights, of course, but also in human resource for health. And with that, I look forward to the discussion. Thank you.
Thank you. We gave you a tough job summarising epidemiology and the demographic and epidemiological transitions for the region. So thank you, and over now to Professor Elena Kickbush.
Thank you very much, Sandro, and I think now I can say good afternoon. I'm delighted to be here, and you can see my delight by the color coordination I have tried with the colors of this conference. Many of you will know how important Australia has been to my life, my personal and my professional life. I've had many, many opportunities to come here, to work here. You can place my age if I say I was present at the creation of the Victorian Health Promotion Foundation and was actually even able to spend 4 months here in Melbourne, living in Carlton, and enjoying the environment. I actually think I wrote one of my most important papers that never got the attention it deserved. Here in Melbourne, it was called "Good Planets Are Hard to Find, the Way Towards an Ecological Public Health." And I'm intrigued when I read many contributions, really important contributions to the planetary health debate that, together with colleagues here in Melbourne working on ecological public health, we had sort of started to tackle some of these issues. I want to, of course, express my respect for country and for the rights and health of Aboriginal peoples. And I would also like to draw your attention that we have produced a very special issue on Indigenous rights and health that we will introduce to you at lunchtime tomorrow. Now, I wanted to talk shortly, and I'll cut some things because time is really running. The theme of the Berlin World Health Summit in 2024 is building trust. And therefore, I wanted to raise some issues around trust and the trust gap. And I guess the other speakers, you heard it, also all in one way or the other mentioned the issue of trust. If we look at academic studies, and they come mostly out of the policy sciences, we can see that trust has been the best explanation or factor for the difference between countries in their successful dealing with the COVID pandemic. And this is a mixture of trust in government, trust in institutions, and trust in other people within communities. And it's very worrying if we continue to look at some of the surveys that are done on trust, that we actually experience diminishing trust in many countries and many societies. I encourage you to look at the Edelman Trust Barometer, which actually shows you that roughly 60% of all Australians trust neither their government nor the commercial entities in this country, nor the media. So that makes it difficult to move forward. That makes it difficult to find commitment for public health actions. But we also see that as countries move forward, do their assessments of the COVID-19 pandemic, when they even embark on that, it seems to me that in many countries one doesn't want to touch it with a barge pole to assess what actually happened during the pandemic. The building of trust, the involvement of communities, that very essence of the health promotion approach that Vic Health stands for, is still neglected. Actually, I was able to moderate a simulation of the G7 health ministers during the German presidency of the G7. And in that simulation, they had various choices of where they would put their priorities. And would you be surprised? The community came last. So we are not learning what we should be learning in terms of the pandemic. And of course, the tremendous inequalities, the inequality of distribution of the vaccine and other means of dealing with the pandemic have also led to a significant distrust in the global community, which is reinforced by the geopolitical situation, which is actually fostered by some countries because they do not want multilateralism to work. And therefore, we have seen how difficult the pandemic negotiations have been that the distinguished regional director referred to. And we have somebody who sat in them regularly here on the panel. And it's definitely not been easy. I tell you, I was there when the Framework Convention on Tobacco was negotiated. That was a piece of cake in comparison with what is happening in relation to the pandemic treaty. Now, as we saw, you can lose trust in a minute, and it will take you years to reestablish it. And we must be critical of our countries that we call democracies, because they have not been investing in their democracy. They have not invested in making young people understand the value of democracy. In Germany, we've just had a major survey, and 1/3 of young people say they do not think democracy is important. And so something is going on in relation to our societies that we need to look at very carefully, and obviously health plays a role in that, but health plays a role in that in combination with equity and fairness, because the trust gap in many cases is related to the equity gap. And we cannot separate the two. And we have seen that during COVID, we were not able to separate them. And then, as I was looking what I had jotted down for this short presentation, and was listening this morning to those wonderful expression of thought from the Aboriginal communities, I said, well, actually we've got it here. What do we need to apply in order to generate trust? Our speaker called it respect, and the respect of self, the respect of others, and the respect of country, which I would add, the respect between countries and moving forward, and the importance of voice, of truth, and of some kind of agreement that one honors the treaty. And I think we can learn for many of the challenges that we face, also in different ways from Aboriginal and Indigenous communities, maybe in ways that we did not even expect. And as we've said, we might need to change some of our language and take it forward. Our language more traditionally is the language of social solidarity and is the language of social contracts. And the social contract aims to express exactly what the Aboriginal communities call respect. It is what we owe one another. And this is one of the things that both locally, nationally, and globally got lost during COVID, the vision of what we owe one another. So as public health professionals, I think we need to strengthen that public health perspective on trust and to start seeing low public trust as a risk factor. And that risk factor of low public trust is linked to the social determinants of health. It is linked to the lack of fairness, and democracies must consider how to address that, because a democracy cannot function if I have an increasingly divided community. And if we are not listening to those that through their distrust are actually expressing to us that their needs are not being met. Now, there is a lot of discussion, and some of this has been mentioned by the previous speakers, of what we are confronting: the increasing polarization, the increasing partisanship, the mis- and the disinformation that we now call the digital determinants of health. But in that list, what we frequently do not find is the reference to discrimination and to very, very deep structural inequalities that need to be addressed. And therefore, it is a key public health goal how to foster that cooperation in low-trust societies and communities, and how to take it forward. Because if we do not succeed, it moves on and on. Health, as Axel Priest told us earlier today, can be a great way to bring people together. And for many decades, that actually happened. You know, during the Cold War, people did speak together on health. It is much more difficult today, and we have seen that during COVID, health became a divider rather than as an issue that brought us together. And we see that this continues, that people are stopping to vaccinate their kids. We have people running around in Europe saying the polio vaccine does not work and is a sham. And social media is helping to move that forward. So I think we as a public health community must have as a public health goal exactly what the regional director said. We need to build resilient communities based on trust. So therefore, we need public health institutions that themselves inspire trust, that become listening organizations, that become centers of co-production. And I would urge every single public health organization in this room to revisit your strategic plans to see whether you have put this in your plan. Establish trust through listening and through co-production, transparency, and cooperation. So I'd like to end with that we must remember that lack of trust in institutions is a health risk. And as health professionals and institutions, we must address this. This is our task. Thank you very much.
Thank you. All right, we're going to jump straight into some questions, and I did have a few themes I wanted to explore, but we're going to go to the heart of it and pick up where Berlin is going to take us later in the year. And at the heart of the conversation today has really been the breakdown in trust. Polarised world, the complexity, conflict, climate, and then, of course, active actors opposing trust, breaking down trust, whether that's foreign governments, whether that's commercial actors, whether that's groups within society. Lucas, I'm going to come to you first, and I suppose my question is around how do we reset, how do we reboot, and what does a regionalised approach look like for building strong partnerships?
Thanks, Andrew. An impossible question to begin with, but I'll try. Thinking about trust in institutions post-pandemic, with a trend that was happening before the pandemic, it's quite vexed. And I think one of the lessons learned for us was that the public health community as a whole, us included, needed to engage social science, behavioral science a bit better. We've seen it in vaccine coverage very specifically. It's hard, and we all experience it around the world, when the information was changing rapidly, you needed to put up what you knew at the time, but explaining how the scientific method works and new evidence actually changes your position when you're trying to maintain a public policy approach and keep people updated in a scary situation is, I think, inevitable to undermine trust that way. But bringing in other disciplines, bringing in other expertise, not just vaccinologists, not just epidemiologists, to help us understand that better and engage in a bit more on what communities we're fearing, and not talking down at people, not dismissing their concerns as misinformed and conspiranoic. Things like that it's something that I don't think we have incorporated well moving forward. That links to what we are trying to do in the region, which is what I alluded to during my presentation, that we really want to, and the mandate from our minister is very clear, continue to establish true partnerships. This is not about donor and recipient countries. There's plenty to exchange both ways. Of course, we engage in development assistance because it's the right thing to do, but this is something that benefits us as well. Stronger health systems across the world make us all safer. We are interconnected. Even if we're an island and we can close the borders, that doesn't work. If we are not all healthy, no one's going to be healthy. So it's the right thing to do, but also good for us. And that's the shift. We don't want to have that vertical relationship that existed before. We want to really sit down, localize our development assistance to what's relevant in particular areas, listen to partner governments and what the priorities are. And we have redesigned not just in health, our whole development assistance program to prioritize what countries want. And and then they can decide what expertise in Australia they can access to then strengthen their health systems.
And there seems to be a theme emerging, I think, across the region, but also under your leadership and Minister Wong's leadership, of much more humility in the way that we think about our responsibilities and our role as a nation. Prof. Adibra, I wanted to ask you, I mean, many of the theoretical frameworks we use for building trust, building partnerships come out of Europe and the US. I mean, are these methodologies fit for purpose? Does a partnership approach in Asia look different? Should it be different?
I think by and large, the framework should be the same, but given the diversity, we obviously need to adapt. And just going back on the trust issue, and we saw this very much during COVID. Whatever the response is, first of all, it needs to be grounded in science. And the complexity of explaining that science, as we saw in COVID, therefore requires the participation of behavioral scientists, social scientists. But I think at the very beginning, what needs to happen is true community engagement and co-design of the science that we do, and which is something that we probably haven't been doing very well. Except, of course, in the HIV world, where the greater involvement of people living with AIDS, became a principle right from the beginning. And I think with that, we see at AIDS conferences, people living with HIV are front and center of not just designing programs, but as speakers, etc., and really owning the issue. And I think that there is a lot to be learned there, both in terms of disease-specific, but in how we work in the region, that having communities truly involved, co-designing research and disseminating the information, I think are all key.
Dr. Sayre, can I ask you, I mean, we're talking about sort of co-designing priorities with the community. I know you're very passionate about a country-led approach, and that's been a hallmark of WHO reform over the last sort of 5 or 6 years. I mean, what role do you see for WHO, and particularly your leadership in the region, in brokering or trying to bring greater trust around health and from health?
I think COVID-19 highlighted the need for a strong WHO. And I don't think there's any other organization has the mandate from member states. Also, the significant country presence of that WHO has. I also think that the world needs a trusted voice in terms of evidence when it comes to health. As we have been discussing about the trust in the communities, I think the lesson learned from the COVID-19 is the community involvement. The role of the Regional Office of Western Pacific now is to implement the reform. The mindset shift from compliance-oriented to a impact result at country level. Shift the focus from regional offices, headquarters, into the member state. I think we sometimes need to listen to them. Sometimes we just dictate, this fund is to implement this. But we are in a diverse region in terms of population, land masses, and economies. The health challenges remains the same, different in scale. But sometimes the best solution comes with the member state, with the communities. Local solution. We sometimes think globally and act globally. But sometimes we need to think globally and act locally. Listen to member states. So we are having implementing this delegation of authority, increase capacity and empower country offices so that they better respond timely to the needs of member states. And I think that's what the mindset shift now to impact result at country level. Thank you.
Thank you. I mean, one of the themes that has come up is the importance of listening and empowerment, but it's really listening. It's understanding your positionality, handing over power. We heard about that this morning. We're hearing it now from all of you. Ilona, you're at the sort of conception of health promotion and seen, various evolutions over time. Kind of from your position of wisdom, I mean, what do you see are the key learnings that we should have in mind, as we look at this fragmented world with low levels of trust and looking to really engage with communities, going beyond rhetoric, but actually handing over power and engaging communities?
Well, as the other colleagues have said, many of the solutions themselves are local. So, but we do have, a deep and a large literature and experiences that we can refer to. You also said that, and in even, still medically dominated global health sphere, we do see that, the knowledge that comes out of communities, that comes out of social science, that comes out of different voices is just not recognized enough. At the same time, I think, and Axel Priest referred to it a little bit this morning, is while we have and while we respect all this diversity, we do have to ask ourselves, do we still have common goals in our global community? And I do have to say that there are things that worry me. I am worried about the rollback in women's rights in global health. And it's not easy to discuss that in the context of multilateral institutions. I am worried about the rollback of the rights of people with other sexual identities in the context of global health. And I am worried that it is difficult in health diplomacy to find the balance between, this power differential on the one hand of, let's say the old colonial, the old West and whatever, and the others, and at the same time finding that some of those, universal values of health as a right, as the WHO Constitution says, do not apply in a large number of countries in the world. And so, how do we maneuver that? And so I think that is a real complexity, and as I said earlier, is also a discord that is literally being pushed by countries and powers that want to weaken multilateralism. And I guess, as a negotiator, you will have that experience that, yes, there has to be a significant change, but what is it that health as a human right really means as its essence. And in that, you know, while health diplomacy is about compromise, in terms of health as a human right, there must not be a compromise. There cannot be a compromise. And that is, you know, really the challenge that we face in global health and multilateral negotiations right now.
Thank you very much. Well, believe it or not, we're out of time. Yeah, let's give a round of applause to our panel. I loved your quote, Alona, low trust is a risk factor. And I think that's something we can all take away as we think to the next few days. So unfortunately, we have run out of time. We've had an incredible lineup to open the 3 days, strong vision, powerful calls to action, fabulous insights. So please join me in giving our wonderful panel one more big round of applause. Thank you, Professors, Ambassador RD. Have a wonderful lunch, and we're going to start, I think, the next session on time and sharp. So please check out the program and be there for the beginning. Thank you again.